Hi there, this is Beth Birmingham, and I'm an occupational therapist certified in hand therapy. And today I get to talk to you about rheumatoid arthritis. And I decided we're doing this on a Saturday, so we're sitting outside and trying to enjoy the beautiful weather. All right, what I thought I'd do for you today is show you a video because pictures are much more entertaining than my words, I think, at times. So I'm going to show you a video that explains rheumatoid arthritis a little bit more. Then we're going to go into the deformities that we end up treating, which are really the MP joints, and then the deformities that we get with the fingers, the boutonniere, and the swan neck. So let's get started on it. Okay.
Rheumatoid arthritis is an autoimmune disease where a person's immune system attacks and targets the healthy connective tissue surrounding joints in the body. It affects approximately 1% of the population. Rheumatoid arthritis most commonly affects individuals aged between 30 and 60. However, onset can occur at any age. Women have more than double the chance of developing rheumatoid arthritis. Other risk factors include having a close relative with rheumatoid arthritis and smoking. When the immune system attacks the connective tissue surrounding a joint, this causes inflammation. Patients experience swollen, stiff, and painful joints, which can feel warm. Symptoms are worse in the morning and after periods of inactivity. The most common joints affected are the small joints of the hands, feet, and ankles. However, larger joints may also be affected. Symptoms usually occur symmetrically on both sides of the body. This initial inflammation can lead to long-term joint damage and joint deformities, so early management is key. People living with rheumatoid arthritis experience flare-ups of more severe symptoms which can last from a few days up to a month. Rheumatoid arthritis is mostly managed with medications targeting the immune system, which aim to decrease the inflammation and damage to the joints. Other medications are given for initial symptom relief, however, these do not combat disease progression. Intramuscular injections can provide relief from symptoms, especially during flare-ups. If the condition is allowed to progress, it can lead to permanent joint damage consisting of cartilage destruction and bone erosion. Depending on the severity of the joint damage, a patient may choose to avail of joint replacement surgery, which serves to ease pain and increase joint mobility. Rheumatoid arthritis is known to cause fatigue. However, keeping active is shown to benefit patients. Regular low-impact exercise can strengthen muscles and keep connective tissue healthy, providing better protection against flare-ups.
I'm going to just pull open my slideshow now. All right, we're going to jump right into some of the interesting hands that you may see with someone who has rheumatoid arthritis. So this hand here is a hand that has become very lax because of the synovial damage that has occurred around the wrist and the fingers. This person, you can actually take their fingers and just keep pulling them all the way back. They're just so gooey. This one's called Mutilin's deformity. And what happens here is when the bone underneath actually shrinks. And so the skin, there's extra skin on top. So you have this more of a telescoping effect of the digit. And then you might see a hand where they have fingers that they can't pull up. And that's because their extensor tendons have been ruptured, typically right here on the ulnar styloid. It becomes very rough and like a knife cuts it. And there are different kind of splints that you can have that helps to modify it and keep their fingers up. But the problem is what happens a lot of times is once one goes, the next one gets ruptured, then the next one, and then the next one. So this typically is a surgery candidate. This is a typical hand that you see. The MP joints are going to be red and inflamed, and you can see here that the fingers are volarly subluxed. They're not here anymore, they're down here. And the little finger sometimes just seems like it's just kind of like fallen off and is just hanging out there on the side. The fingers you can't really tell here, but it looks like there's more of a swan neck deformity going on in those fingers. And the thumb is very large right here and hyperextended at the IP. Looking at the metacarpals, you will see, and with a lot of deformities, you will see that it goes into a zigzag. And it does that because the body is trying to realign it back to, for this instance, the forearm. When the carpal bollii subluxes, the tendons get pulled different directions. So what you're going to see is you're going to see that the fingers end up drifting over ulnarly. The metacarpals are going to be drifting radially, and then you have the carpals that are drifting ulnarly again. So you get the zigzag effect. And the tendons, the extensor tendons, they fall down over to the ulnar side, and thus they're pulling them ulnarly. The other type of deformities, you see the swan neck and the boutonniere deformity. And again, it's about this time the lateral bands being pulled either up or down, which are going to cause the joints to pull different directions. So how do we treat them? One of the ways the rheumatologist is going to treat them is trying to figure out what type of DMARD or disease-modifying anti-rheumatic drug is going to work for them. And like the video said, it's really about how do we stop the inflammation? How do we stop the proteins that are in our body, in our immune system? How do we stop them from attacking our healthy tissue? So they're going to try to figure out which biological agent or modifier is going to be best with that individual. A lot of times they will combine it with the DMARD methotrexate, and they're going to try to figure out how can they stop this inflammation from occurring. But we are going to look at more how can we help their pain, change the way they're doing their things in their daily living tasks so that they stop the deforming forces on their inflamed joints, and what can we do to help modify the way that they use their hands when they are in a deformed position. So with the ulnar drift, we're going to look at seeing, first of all, if the metacarpals or the fingers can be brought back to neutral. Are they stuck over here, or can we reposition them back to a neutral position? Does the person have good IP function still? The PIP joints are key to function. When they don't bend as much, the function, your ability to grip is a lot less. The other thing is looking at intrinsic tightness. Intrinsic tightness is when you have the intrinsic muscles, like the lumbricals and the dorsal and volar interossei. It's when they become tight. And if they become tight, they attach here and then they go on the side right up here. When they're tight, a person's not able to pull their fingers in like this. It's going to look like this. They're going to only be able to pull them about this far. But when they come down into a fist, when the little muscles are looser, they can make a fist. So they can do this, but when they come up, they do this. I have my dog scratching at the door. I'm going to ignore her. Here is an example of the test. It shows in A that they're not able to pull their fingers in, and in B, they're able to pull it in. And what I'll do is I will check, I will feel what their fingers feel like in this position, and I will feel what they're like in this position. If they're more than 1 centimeter distant, a difference from here to here, then they probably have intrinsic tightness. So treating the correctable ulnar deviation, we want to look at stretching those intrinsics. Once they master stretching the intrinsics this way, you can make a splint that blocks them here and they can exercise in this position. You can get them to stretch them. A lot of times I'll get them to stretch them on their thigh and stretching their intrinsics. And once they get it good at this type of intrinsic stretch, then I'll get them to add on a radial stretch to it. So working on extending the finger up this way, as well as stretching them over this way. And I'll do this one individually to each finger, as opposed to the first one I do it with the fingers all together. All right, and then again, it mentions the splint, making a custom thermoplastic splint that folds their fingers up like this so they can actively stretch those intrinsics. Also, you might be looking at a nighttime splint to just rest their fingers in a neutral position. All right, the intrinsic stretch, there it is. Now, if the ulnar drift is severe and you cannot manually correct them, then, actually, sorry, this one is they're severely subluxed, but you still can manually correct them, then you're still looking at the intrinsic stretches and making sure that the IPs are still flexible. You want to see if you have x-rays, what do the joints look like? What's the articular destruction that's present? And then from there, you're going to again be looking at intrinsic stretches, what kind of splint will help with their pain, and what kind of splints will help with their function. Here is again another example what the fingers look like and what some splints do to help correct them. Here's an example of a neoprene one that's been around a long time. You can see the difference between here and here. Though I do find that patients find it's a little irritating between the fingers, so I've kind of moved on from this splint. This is a splint that Bennick makes, and they have these Velcro bars that pull the fingers up at the MPs. And if it is just one finger, you can use just like a pencil. If you had something in between, it holds the finger up higher. Making a yoke splint holds the finger up higher, so when you move, it's always a little bit more extended so that the extensor tendons don't flip over ulnarly to the ulnar side of the MP joint. This is a type of splint that has the thermoplastic material here, and then it comes around the back. So again, they're holding the fingers up like this so that they can extend their MP joints. And I don't have a splint here at home, but I typically make a splint that goes around here. So I'll cut out this area here because I don't want anything to rub on their swollen MP joints. So it circles around here. And then I will put neoprene between each finger and through the splint material and through the finger and through the splint material. And so that there's loops around each finger. And so they have a little bit of a stretch that springs their MPs back up, but they hold them more in an extended position. So I've been making a splint more like that more recently. And this is an example of a resting hand splint that's keeping the joints in a neutral position as opposed to a Z deformity. With severe dislocation, and if you try to correct the fingers, you can't. And in that situation, they're a surgery candidate, and you might end up, the patient might end up having MP joint arthroplasties. Thank goodness for the biological medications nowadays. I don't see as many people that have these, but there are still people that do have side effects, or they don't do well with the medicine. So I still do see some patients that have very bad deformities that could benefit from arthroplasties. If someone does have this surgery, it will take a good 3 months before they're really allowed to do more use of their hands. So it's important they know that it's a good 3 months of rehab that they will be doing. So the biggest thing is for a good 10 to 12 weeks, you really want to make sure that there's no lateral stress on the fingers to encourage them to go laterally once again. The other thing is that you are slowly working on flexion, where in the first 6 weeks, it's only 45 degrees that you're working on. And then eventually you increase it more to 85, but you don't stress farther than that because these type of arthroplasties have a tendency to fracture, the prosthesis fracture, and then you go right back to square one and you have the ulnar deviation and the extensor leg, and that's not what we want. So it's a slow process of getting some range of motion back, but not trying to get all of it back. Swan neck deformities. This is a nice little picture over here of how the lateral bands slip above the PIP joint, so it hyperextends it, and then it slips where it actually pulls the tip down so that you have more like a swan neck. That's why they call it. Looks like a swan swimming in the water. And the interesting thing is it can originate anywhere. If someone has like a mallet finger, that could encourage a swan neck deformity. With rheumatoid arthritis, a lot of times it's the MP joints because they get inflamed, they stretch everything out, and then the ligaments get pulled different ways in the lateral bands. So with a swan neck deformity, you're going to be looking at more figure 8 splints, a splint that prevents the PIP joint from hyperextending. And there are oval 8 splints that we talked about with osteoarthritis that you can get on Amazon that are plastic. And there are silver ring splints that you can get that are more permanent, that look just like pretty rings, and you don't even know that someone's wearing a splint. And then you can also make splints. What I think I want to do too is take you to the Silver Ring Splint Company, their website, because they do a really, really good job at explaining what the splints do and what kind of deformities are there and how you can correct them. So I'm going to take a moment here to stop and stop sharing this screen. Okay, and let's see, sharing my screen this time. So when you go to the website, at the top, you'll see the problems addressed. This is a nice area to go to because it shows what different deformities the hand can have and then what type of splint would correct that type of deformity. So this is an example when the IP hyperextends. I'm going to go back. And then you can see the first page really just shows different deformities. You look up what's going on with your patient, and then you go and you see the splint option, and then they'll show you what would work for that patient, for that client of yours. Interesting, pretty splints. Also, in the therapist section, they will show you how to go about measuring the silver ring splints. And what you do is you would get from the splint company these rings, measuring tools that have a ring size, I think like 1 to 15, something like that. And they have half sizes in between. And they pop off this little bar and you get to slide them in these little attachment areas and try them on as if they were really a splint. So here's an example here. If you were looking at the swan neck deformity, you would pop off from up here. You would pop one of them off, hold on it, it pops off, and then you would slide it on their finger at 45 degree angle. It's where the bar is straight to the ground. You slide it on, you try to figure out what size just fits. That's a little snug, but you can slide off. And then you put it into the little attachment. This is again for the swan neck splint. And then you would go and try a smaller circle, a smaller ring, and then you would have the opposite direction. You'd slide it on to where the crease is of the PIP. And then again, try to find the right size that you can slide on, but you can still slide off. And then you pop it into that little attachment. And then now you have this like little plastic ring, figure 8 splint. You slide that on and you see if that's right. Now let's say you order that splint and it's a little bit too tight. What you can do is you can take the silver ring splint rings and you can push them a little bit together and that'll make them a little bit looser. Or if it's too loose, you can push them the other direction and you're gonna get them to be a little bit tighter. Okay, Tavin, I'm typing. Can you go back inside, please? Please? Okay, I have my son joining us behind.
Hi.
Okay.
Is this the whole team?
No, you can just sit down there. I'm teaching.
Oh.
Okay. Anyways, that's the Silver Ring Splint Company. It's a great resource. Okay, we're gonna try to go back to my slideshow now. Let's see. Go back here. Here we go. And voila. So, splints, we've done that. Another way to work on helping the swan neck deformity is the stretches. So again, we would look at the intrinsic stretches, the hook, and as well as working on the pattern of doing a hook, fist, hook extension, getting them to work on this because they have a tendency to do this to pick up different types of anything in the day. And when you're doing this, you're actually strengthening your intrinsics. So by teaching them to do this, we're working on making sure that we're stretching the intrinsics and a better biomechanical pattern. So with a swan neck deformity, if it is severe and you cannot put it back to neutral, patients will go for a fusion, perhaps an arthroplasty, but again, they are unstable and they fracture. And so a lot of times they might get an arthroplasty, but they have to go and get it fused afterwards. We're moving on to the boutonniere deformity. Boutonniere is really buttonhole, and they call it a buttonhole because the lateral bands, they spread and then the PIP joint pops through the lateral band. So if the bands are now below the joint, they're going to be a flexor. So they pull the PIP joint bent and they're going to be on top of the DIP joint. And so they're going to pull the DIP into extension. This is a flow sheet that you can follow. If the PIP and the DIP joints are correctable, then, let me see if I can move this over a little bit. No, I guess not. Okay, sorry. Then, okay, let's say that it is correctable. Then you want to look at splinting them, trying to work on getting the PIP to extend and working on the DIP flexing. So here's an example of a splint that you can make to work on the extension of the PIP joint. And again, remember, these boutonniere deformities are correctable, so you can get them up to here, you can splint them like this, and then you can work on bending the tip. Doing this exercise actually helps to work on taking those lateral bands that have become more of a flexor and trying to pull them back into extension, pulling them back on top of the dorsal PIP joint. You can do the opposite too, where you make a splint that bends the tip, and then you can exercise by trying to extend the PIP joint. And if you have the tip bent and this bent, it puts a lot of force on the PIP joint to again try to pull the extensor tendons or the lateral bands back on top. Another condition that comes with rheumatoid arthritis is Raynaud's disease, and that's when the blood vessels spasm, and so they don't get the right blood flow to the fingertips. In the cold weather, they go white, and when they warm up, they go purple. And sometimes what happens is their fingertips, they can lose their fingertips because of the poor blood flow. Another condition is cryoglobulinemia. That's a nice word. And that's when the proteins aggregate and become more jelly-like, and they impair the circulation in this form. And because of that, again, because you don't get the blood flow, you can have the gangrene, the lack of flow, which again, they can lose their fingertips. So let's now look at boutonniere deformity. Let's say that you cannot correct the PIP and the DIP. This is good when you can get x-rays, because if you can see that the joint integrity is still intact, that's when you can look at casting and more of a low, prolonged stretch to see if you can straighten out the contracture that's present. or you can look into serial casting or serial splinting to slowly correct the deformity. If the x-rays show that the joints are they're destroyed, then you're not going to be looking at casting. You're going to be looking at surgery, and again, perhaps fusing or arthroplasty, or really working on the soft tissue around the joint to see if they can release it and get it in a better position. So this is a summary of the role of the therapy and the splinting per stage of arthritis. Stage 1 is the acute stage, when it's inflamed, it's red, it's hot, swollen. So you're going to be looking at ways to control their inflammation and their pain. You're looking at cold modalities or cool modalities, relaxation, educating them on the disease process, looking at orthoses, isotonic gloves to help with the stiffness that they have when they're sleeping, nighttime splints, resting splints. You also want to look at preserving the joint mobility, so gentle range of motion within their pain limits. Joint protection, education. Can they use 2 hands, their palms, larger muscles? Trying to change the force where there are no muscles, and just trying to prevent the deforming forces. And looking at their overall health and how can you maximize their health. Restorative sleep, nutrition. With the stage 2, they call that the subacute stage, and it's still an inflammatory disorder. So you still would be looking at cool modalities and looking at how you can get rid of the inflammation and the pain, looking at the splints, looking at gentle range of motion, intrinsic stretches, isometrics where you're working on your muscles but you're not irritating the joints, fatigue management with energy conservation, and how can you improve their function? What are the things they're having difficulties with in their daily life, and what can you do to help them still do them without causing the deforming positions? Looking at assistive devices and modifying their positions. And in the last stage, stage 3, you have the severe stage, and that's when they've matured. They've really, at this stage, it's not as much swelling, but more stiffness, and you're going to be dealing this time more with heat modalities. What can you do to help get rid of that stiffness, and looking at still, how do you preserve the joints from further deformity, using energy conservation techniques, assistive devices, splinting, restorative sleep, health, nutrition, fitness, stress management techniques. And this is the last slide. This is more just helpful resources that you can refer to. We looked at the Silver Ring Splint Company today, but the Arthritis Foundation is an excellent resource. It is in Atlanta, and it's a great place to look at all the different medicines that are out there, as well as holistic medicines and other important information to help someone who has rheumatoid arthritis. And the other sites are more related to, well, the Arthritis CA is a Canadian site. They're Arthritis Foundation, but they're Arthritis Society. And then we have the ASHT, the AOTA, the APTA, hand surgeon sites. And then I go to the Journal of Hand Therapy often to try to find out more. What are they doing with research and what's evidence-based? Again, we want to try to do practice that is evidence-based and is going to be something that is going to benefit our patients or our clients. All right, that's it for today. I hope that's been helpful. I'm going to stop sharing the screen here. And if you have any questions, you can ask Helene to get maybe my email, and I can email you. And hopefully I can help you understand this a little bit better. I'm looking forward to you guys getting out here as occupational therapists, and good luck with your studying. Take care.